Good evening, everybody. Thank you so much for giving your precious evening to spend some time here and get educated on lung cancer. My name is Joyce Palos. I'm a medical oncologist, and I'm going to be talking to you about lung cancer today. So this is a brief overview of what I intend to talk about. We have quite a bit of information to unpack, so I'm going to try to hit through some of the key points on a few subjects. So first thing, we'll talk a little bit about the epidemiology and some risk factors that are associated with lung cancer. We'll talk about the importance of screening and what the modalities are available for screening. We'll talk about the process involved in diagnosing lung cancer, as well as the process of staging. And then finally, we'll touch on some of the options that are available for treatment, the various types of treatment options for lung cancer at various stages. To start off with, to answer the question, what is lung cancer? So it's a type of a disease that, and where you have cancer cells that form essentially in the tissues of the lungs. So it's important to understand at least the basic anatomy, and I know it's a complicated picture here, but I'm going to try to break it down for you. The lungs, as you see here, it's a pair of cone-shaped breathing organs in the chest. They bring oxygen into the body, and they allow you to release carbon dioxide, which is a waste product of the body's cells, as you breathe out. Each lung has lobes, the different sections. The left lung has 2 lobes, the right lung, slightly larger, has 3 lobes. There are 2 tubes, as you can see here, called the bronchi. And then at the very end of the tubes, you have these little air sacs called alveoli, and that's precisely where gas exchange occurs. Lung cancer develops when the lining of these cells start to turn cancerous, and then eventually they turn into tumor. There are different types of lung cancers out there. Most commonly is what we refer to as non-small cell lung cancer, which is about 85% of all types of lung cancers. And then 15% or so of patients who have lung cancer have a type of lung cancer called small cell lung cancer. Even within non-small cell lung cancer, there are different types of non-small cell lung cancer, different entities, if you will, most commonly being adenocarcinoma. So usually adenocarcinomas start in the cells that normally secrete substances such as mucus, so they're gland-forming cells. Oftentimes very strongly associated with smoking or former smokers, but it's also the most common type of lung cancer that develops in patients who are never smokers, usually found in the outer parts of the lungs, what we call the periphery. The second type of lung cancer that is called squamous cell carcinoma. So this is usually located in association with the bronchioles or the airways. They tend to be much more centralized in location and very heavily associated with smoking as well. Then there are different types of non-small cell lung cancers, for example, large cell carcinoma, and then a small percentage of people who have something called carcinoid tumors. These are also cancers that form in the lungs that can secrete certain hormones, and oftentimes tend to be pretty slow growing, or what we call indolent, and usually have a pretty good prognosis. And then 15% or so of patients who have lung cancer have a type of cancer called small cell lung cancer. Essentially, this is based on what the cells look like under the microscope, and that's precisely how you distinguish small cell from non-small cell. As you can see here, there's a picture of small cell lung cancer. This is characterized by these small, round blue cells. They tend to be very aggressive. They're very fast growing compared to the other counterpart, the non-small cell. So that's kind of how you distinguish between small cell and non-small cell. So we'll talk about some facts and some numbers. Lung cancer is the leading cause of cancer death. Among the types of cancers that are known to be deadly, the top 5 at least, lung cancer is the top number 1. This year, more than 235,000 Americans will be diagnosed with lung cancer. So it is among the top 3 most common type of cancer in general. It affects both men and women, and it affects all types of races. And anyone can get lung cancer. It is important to note that up to 18% of patients who have lung cancer are never smokers or have a very remote history of smoking as well. So as you can see here, this is information that I pulled from the National Cancer Institute, there's something called the SEER database, or Surveillance, Epidemiology, and Results Program. This is a database that tracks and records a number of cases of different types of cancers over time. And this provides some good statistics on incidences and prevalence. So as you see here, lung cancer is the third most common type of cancer. And in 2021, a little over 235,000 cases will be diagnosed. However, among all these types of cancers, lung cancer is the leading cause of cancer-related death. So it is the most deadly type of cancer. And it represents about 12.4% of all new cancer cases diagnosed in the US. As you can see here, this is a graphical representation of the incidence of new cases diagnosed, as well as the survival. Back in the 70s, you used to see this number right here, which peaked into the 90s and largely has to do with the increase in smoking habits that prompted the uptick here. And then as you head into the 2000s, or the past 2 decades, the number of cases that are diagnosed have actually declined. And this largely reflects the patterns of smoking and decreases in smoking. And also, similarly, you can see the death rate and survival has also improved over time. And this is largely attributed to the advances in treatment, as well as the advances in lung cancer screening that has been able to catch cancer at an earlier stage and hence treat it with a better outlook. This graph talks about the distribution of age. The median age of diagnosis at 71, so that's where the vast majority of patients are diagnosed. Prognosis ultimately depends on the stage of the disease. As we know, there are stages. With every cancer, lung cancer has stage 1, 2, 3, and 4, and we'll get a little bit into the detail as the presentation proceeds towards the end. But all stages combined, the 5-year relative survival is about 22%. What that means is this is combining stage 1 to stage 4. Out of 100 people at 5 years, 21.7% of people will be alive. And as you can see here on the right, largely the 5-year survival depends on the stage at which the cancer has been diagnosed. So in patients where the cancer is caught early, what we call localized disease, the 5-year survival rate is close to 60%. When the cancer has already spread to the lymph nodes, the 5-year survival is closer to 33%. But if the cancer is already advanced by the time it's diagnosed, this 5-year survival is close to 6%. Now, these numbers are based on the SEER statistics in the database dating back 5 years or so. There is a little bit of a lag time there. So there are newer treatments that have been developed and utilized and practiced that have potentially changed these numbers and will continue to change these numbers for the better in the years to come. So risk factors for lung cancer. Perhaps the most important thing to know is, well, how does lung cancer develop? Lung cancer, just like any other cancer, develops when cells grow out of control. Now, normally, if you can see, cells in the lungs have a specific growth and death cycle that keeps the numbers in check. There's a checks and balances in place. Changes in the cell's DNA, or the genes, the instructions that provide the basic code, and these are called mutations. These changes can cause a cell to grow without any checks and balances, so without any regulation, and that's how tumors form. Now, changes sometimes can be detected by the body and it will be eliminated, or be corrected, I should say. But sometimes there are certain changes that can be not detected by the body, and when it goes missed, those changes accumulate in a cell, and eventually the cell starts to grow out of control, and that's how a tumor develops. And those changes then eventually become part of the cell's blueprint, or the DNA, and that's how cancer spreads. What are the risk factors that would increase the likelihood of developing these changes? Smoking, as we alluded to earlier, is perhaps the strongest risk factor for lung cancer, and it accounts for up to 90% of lung cancer diagnosis and 80 to 90% of lung cancer related deaths. So compared to non-smokers, the risk can be as high as 10 to 30 times. So that's quite a substantial risk. And the risk is not only the mere habit of smoking, it increases with the number of cigarettes per day smoked, as well as the lifetime duration of smoking. So it certainly is very different for somebody who's smoking for 5 years as opposed to somebody who smoked for 15 or 20 or 30 years. The risk substantially increases over time. So it's more of a cumulative effect. What are other risk factors? Well, radon is a type of a gas which is now, according to the EPA, the second leading cause of lung cancer. Radon is a colorless, it's an odorless radioactive gas, naturally found in soil and rock, and it forms naturally from the decay of radioactive substances such as uranium and radium. And this is found in the soil and the rock and can get into the atmosphere and into the air through cracks or slip or any crevices in the foundation of a home. So usually it's much higher where the house or the floor is closest to the ground. So the basements or crawl spaces, that's where radon is usually the highest. And it is interesting to note that 1 in 15 homes have high radon levels. And this is something that can be tested. So radon can be high in newer homes as well as it is for older homes. So it'd be very important to check radon levels to see if that's a contributing factor. Of course, people who smoke as well have a compounded effect of both exposure to radon over time as well as smoking. So that is an important risk factor for lung cancer. Other risk factors, there are certain occupations that increase the likelihood of exposure to certain carcinogens such as asbestos, arsenic. So people who work in all kinds of mines, mills, textile plants, places where insulation is very heavily used, shipyards. So that's where asbestos is very heavily seen. Also increases the risk of different types of a cancer called mesothelioma, which is a cancer of the lining of the lungs. So lung cancer can also be seen in patients who have pre-existing lung disease, such as chronic obstructive pulmonary disease or COPD or emphysema, perhaps because of shared environmental exposures, primarily smoking or other types of diseases that cause damage to the lungs. Pulmonary fibrosis is another type of a lung condition where there's scarring in the lung tissue. Eventually, over time, can lead to cancer. Air pollution, so several different pollutants that are inhaled, especially in very heavily trafficked areas. Emissions, carbon emissions. Some research estimate that worldwide about 5% of all deaths from lung cancer can be due to outdoor air pollution. In patients who've had prior exposure to radiation because of treatments. So for example, younger patients with Hodgkin's lymphoma who have radiation to the chest over time, yes, can increase the likelihood of lung cancer. So these are all potential risk factors for lung cancer. So it's not a single solitary risk factor. There could be multiple different risk factors, and over time, these tend to have a cumulative effect. As Benjamin Franklin famously said, an ounce of prevention is worth a pound of cure. So, of course, if there are modifiable risk factors, that is the best strategy to prevent the development of lung cancer. And perhaps the most important of this is smoking cessation. Clearly, there is a reduction in risk after smoking cessation as early as 5 years after quitting, and this risk continues to decline over time. Ex-smokers who have quit for longer than 15 years have up to a 90% reduction in the lung cancer risk versus people who are actively smoking. And this smoking cessation can actually add an extra 6 to 10 years of life expectancy in patients who have chronically smoked because of reduction not only in lung cancer, but other types of cancers. And it's important to note that once a patient is diagnosed with lung cancer, it's never too late to quit, because the benefits of quitting extend to patients who have already been diagnosed or even been treated for lung cancer, because primarily it helps to prevent a recurrence in that lung cancer. And it also prevents the recurrence or the development of other types of cancers that are strongly associated with smoking. For example, bladder cancer, kidney cancer, pancreatic cancer, head and neck cancer, throat cancer. So certainly, it's an important thing to keep in mind that smoking cessation clearly will decrease the risk, and it's never too late to quit once somebody's already diagnosed. So we'll talk a little bit about screening and early detection and why it's important. Screening can detect lung cancer at a stage where it can be treated with the goal of cure. So the whole goal of screening is to pick up early disease, because we know that from the chart that I showed you earlier, the chances of survival are far higher when the lung cancer is diagnosed at an earlier stage and treated at an earlier stage. So the whole intention of screening is to be able to catch it before it grows and spreads and causes symptoms. As you can see here, localized cancer is only found about 17% of the time, or so only a minority of cases where lung cancer is caught when it's still confined to where it originated, right? More than 50% of the time when lung cancer is diagnosed, it has already spread to other places. So it's already advanced. And that's why screening is particularly important. How can screening be done? Well, there are modalities of screening, and the most important modality is using a technique called low-dose CT scan or low-dose computed tomography. And historically, X-rays had been used when patients present with cough or shortness of breath. But these low-dose CT scans are far more sensitive and can pick up smaller lesions that otherwise may not have been picked up by X-rays. And so when you say low dose, they emit a shorter or less radiation than your traditional CT scan. And so it's far more, smarter, if you will, in picking up lesions earlier on, and that can jumpstart the process of diagnosis if a suspicious lesion is found. And the whole idea of lung cancer screening was based on this large trial called the National Lung Screening Trial, or NLST, which looked at over 53,000 patients, who had, or participants who had been smoking more than a pack per day of cigarettes for at least 30 years, aged between 55 and 74. And this study basically randomized these people either to receiving low-dose CT scans, as I mentioned, or traditional chest X-ray, and looked at the endpoint, which is death from lung cancer, and followed them with a median of about 6 years. Now, ultimately, what you can see here is the patients who underwent screening with a CT scan, there was a higher incidence of diagnosis compared to chest X-rays. And then when you look at death from lung cancer, when we look at survival, patients who underwent screening with a CT scan had a better survival compared to patients who merely went through a chest X-ray. So ultimately, this translated into a 20% reduction in lung cancer death in the patients screened with CT compared to X-ray. So not only is it pick up the cancer earlier, it actually allows patients to live longer from lung cancer. So hence, the United States Preventative Services Task Force, or the USPSTF, came out with screening recommendations for lung cancer. I believe it was at least 5 or 6 years ago, or even longer, when they first came out with the first set of recommendations. And the most up-to-date recommendations applies to the following situation. Adults aged 50 to 80 years old, adults who have at least a 20-pack year smoking history. So when I say 20-pack year history of smoking, we're referring to the number of cigarettes per day smoked times the number of years. So 20 years smoking history is, as you can see, 1 times 20 years. Now, this could also be if you smoke 2 packets of cigarettes per day for 10 years, it will be equivalent to 20 pack years. So the age and the number of cigarettes that's smoked and the years of smoking, and patients who are currently smoking or quit within the past 15 years. So these are the patients that qualify for lung cancer screening. And how to screen is with a low-dose CT scan once a year. So that is the recommended modality of screening in this patient population. This is currently the criteria that is used by most insurance companies to approve the low-dose CT scan. Now, there are patients who may have symptoms that would prompt sooner evaluation, and that's not screening. That's really more so diagnostic. So that's with a different type of CT scan. So how do we make the diagnosis, and what is the procedure of staging? So what does screening really detect? What is the rationale of screening? What are we looking for? So CT scans, low-dose CT scans, are looking for these abnormal growths, often referred to as pulmonary nodules. And they manifest as either solid appearing or part solid appearing, or sometimes opaque lesions or growths that are either rounded and smooth or maybe spiculated or with spikes. So there are different characteristics to these nodules. Nodules that are more solid or part solid tend to be more cancerous, tend to be more associated with cancer. And then you can differentiate nodules based on the shape. If they're more round, they're less likely to be associated with cancer. If they're more uneven and have spikes, they're more likely to be associated with cancer. So that's what these screening CT scans are looking for, these abnormal nodules. And depending on what these nodules look like, depending on the shape, the size, there are recommendations for how to approach them. Is it a matter of repeating the scans in 6 months? Is it a matter of repeating the scans in 12 months? Or are these nodules concerning enough that we need to proceed with additional diagnostic steps right away? Now, abnormalities on CT scans or chest x-rays can also be detected when patients present with symptoms of lung cancer, which include chest pain, upper back pain, shoulder pain, a cough that never goes away or just continues to get worse, sometimes coughing up blood, frequent infections, multiple hospitalizations for pneumonia because of lung cancer that's preventing the secretions from being excreted appropriately, weight loss, loss of appetite, changes in the voice, wheezing that it's new or difficult or different from the usual, shortness of breath. So these are all symptoms of lung cancer, but by the time these symptoms start to manifest, sometimes the cancer has already grown and spread to other places, whether it's nearby lymph nodes or other distant areas of the body. So once there is an abnormal appearing finding on an imaging study, a suspicious appearing nodule or a tumor or a mass that is concerning for lung cancer, the next step really is to get a piece of that tissue. And this is called a biopsy. And there are a few ways to get a biopsy. The most commonly utilized approach is what's called an image-guided needle biopsy. This is a procedure that is undertaken by a specialist called an interventional radiologist. So under guidance of a CT scan or sometimes an ultrasound, which is used to localize the area where the lesion is, a needle is inserted from the outside, and then small pieces or samples are taken, called a fine needle aspiration or a core needle biopsy. And that's then analyzed under the microscope, and that is ultimately what gives the diagnosis of lung cancer and the type of lung cancer. And this is usually very useful if the nodule is isolated or located, usually in the edges or the periphery of the lungs, usually in the very top or in the bottom or the sides, because it's easily accessible with this needle. Now, sometimes when the cancer is located very central, so as you can see here, right where the airways are or surrounding the airways, an alternative approach is a procedure called a bronchoscopy. And then this is where a lung doctor, also called a pulmonologist, does a procedure by inserting a tube that has a camera attached to it into the airways, which is then guided through into the windpipe or the trachea and then into the airways, where a lesion can be visualized or accessed, and then a needle is then inserted to be able to grab a piece of tissue that is nearby. Similarly, an endobronchial ultrasound is another type of a procedure where an ultrasound probe is attached to the bronchoscope, and then using ultrasound guidance, this probe can localize to the area of a tumor or a suspicious appearing lymph node, and then stick a needle in there to grab a piece of tissue. So these are ways to get a sample of the tissue in order to make the diagnosis. What is staging? Well, staging is the process that describes where the cancer is located and really tells us whether the cancer is localized or has it spread to other areas, whether it's the opposite lung, whether it's the lymph nodes, whether it's outside of the chest. And really it helps to identify what organs are affected by the cancer. It's extremely important to do the staging process because the accurate stage is what ultimately dictates the most appropriate treatment plan. Stage 1 is treated in a very different way than stage 4. So that's why it's very important to do the staging studies to get a sense of where the cancer is and what stage the cancer is. How can staging be done? Well, a commonly used imaging test is called a PET scan, and some of you may have heard of this. PET scan is oftentimes combined with a CT scan, and it's used to determine whether the cancer has spread to the bones, the lymph nodes, or other organs. So this scan is usually done by injecting a special type of a dye called FDG, or fluorodeoxyglucose. It's a radioactive sugar dye. It's given through the IV, and the whole premise of the scan is that cancer cells will take up glucose much more readily than normal tissue does. So when the glucose dye localizes to cancer, it will appear as bright on a PET scan. So as you can see here, the tumor is much more bright than the surrounding tissue. Similarly right here, the tumor is very bright. So areas that are bright on the PET scan are oftentimes most consistent with the areas that are involved with cancer. So PET scan is a very useful test to help detect where in the body, particularly the other organs and the bones, if the cancer has spread. Another type of imaging test, which is very commonly used, is called an MRI, or magnetic resonance imaging. And this is particularly done, and this is done on the brain, primarily to detect if the cancer has spread to the brain. Lung cancer, among a few other types of cancers, are among the top 5 cancers where there's an increased tendency of spread to the brain. So that's why it is very routine, even in patients who do not have any symptoms of headaches or changes in vision or neurological symptoms, to get the brain scan done because of the tendency of the lung cancer to spread to the brain. So an MRI uses magnetic field and computer-generated waves to create images of the organs in the body, and it's very accurate in detecting whether the cancer has spread to the brain. And this is an example of an image of small cell lung cancer that has already spread to the brain. It will manifest as spots, and oftentimes will be associated with symptoms, but sometimes can also be associated with no symptoms at all. So that's why we do these MRIs as part of the staging process. We use a system for staging called the TNM Staging System. This takes into account a couple of features. T stands for tumor, and there are numerical values assigned to the T ranging from 1 to 4, and directly corresponds to the size of the tumor and whether or not the tumor has invaded into adjacent structures. Is the tumor confined to the lung, or is the tumor invading the chest wall, the spine, or the pericardium, which is the structure that surrounds the heart? N stands for node, and this is also numerically assigned between 1 and 3, and this corresponds to whether or not they're spread to the adjacent lymph nodes, whether it's regional meaning lymph nodes in that same region where the tumor has originated, or whether the lymph nodes are spread. And then also the numbers on the end correspond to where the lymph nodes are located. Are the lymph nodes surrounding the airways? Are they in the chest wall? Are they upper in the neck? And so these numbers differ based on where they're located. And then finally, M stands for metastases. M0 or M1 basically means whether the cancer has spread to distant sites outside of the lung where it originated. If the cancer has spread outside of the chest, if it's, for example, in the liver, in the bones, in the brain, in the adrenal gland, or the opposite lung, it will be called M1. So that is indicative of spread. Now, this TNM staging system is most commonly utilized for non-small cell lung cancer. For small cell lung cancer, yes, the TNM staging can be used, but oftentimes the way we approach small cell lung cancer is whether it's limited or extensive. Limited being if it's in the chest, if it's in one lung, where it can be easily radiated. If it has spread beyond the lung, then we call that extensive stage. So that's how we kind of distinguish small cell from non-small cell. So the different stages of lung cancer. This is a picture of lungs and the associated lymph nodes. As you can see, the lymph nodes are these green structures. They look like little beads or beans that we all have from the neck down all the way to the groin. They serve many purposes, among which include draining excessive fluid. It acts as a filtration system. It's a housing unit for some of the immune cells. So every organ has lymph nodes attached to it. And one of the first areas when cancer spreads, it spreads to the nearby lymph nodes. So stage 1 is when the tumor size is still small, less than 4 centimeters, has not spread to any lymph nodes, and it involves only one lung. So it stays where it originated from. So we call that localized disease. Stage 2 is called regional disease. Regional means, well, the tumor is slightly larger. It can be as large as 7 centimeters. It involves the lymph nodes around the airways, but it's still confined to one lung. Stage 3 is what we call locally advanced disease. Locally advanced disease means, well, it's still local, but it's still advanced. So let me explain. These are larger tumors, larger than 7 centimeters. They have spread to nearby lymph nodes. Now, these lymph nodes are a little bit more extensive than the lymph nodes immediately surrounding the tumor. So these could be lymph nodes in the chest wall, called the mediastinum, or the space between the chest, the lungs, and the heart. This could mean the lymph nodes upper in the neck, called the supraclavicular region. And so this is slightly more advanced than just stage 2. This also corresponds to tumors where there is invasion of the chest wall, tumors that invade the heart, tumors that invade the mediastinum or the spine. Or if there are multiple tumors within the same lung, that's also referred to as locally advanced or stage 3 disease. Stage 4, of course, is advanced disease. And this is when the cancer has spread to the opposite lung from where it originated. So if the original cancer was in the right lung, and then you do the scan and you see spread to the other lung, or if the cancer has spread to outside of the lung. The lung cancer spreads through the lymphatic system or through the blood circulation and sets up shop elsewhere. For example, the adrenal gland, the liver, lymph nodes outside of the chest, in the abdomen, the pelvis, the bone, the brain. So if there is spread, then we call that stage 4 or advanced disease. So I'm going to talk now about the treatment or the generalized approach to treatment and what the treatment options are for lung cancer. So we'll talk about the overview of options. These are the different types of modalities that we utilize to treat lung cancer: surgery, radiation, and systemic therapy. So these are the 3 different types of treatment modalities for approaching the management of lung cancer. Surgical resection is essentially removing the tumor. And this is often the standard treatment for early stage disease, stage 1 or stage 2 disease. Essentially involves removing the tumor and a part of the surrounding lung tissue, as well as the lymph nodes. There are different surgical approaches. One commonly used approach is called lobectomy, where the entire lobe of the lung that houses the tumor is removed, as you can see here in this picture, removal of an entire lobe. Another type of surgical approach is called wedge resection, essentially removing a small portion of the lung that contains the tumor. And this may be appropriate if the tumor is very small or located at the very edge, or in patients who have multiple diseases, lung diseases, where you cannot afford to remove a good portion of the lung because of pre-existing lung compromise. So when you remove a small portion of the lobe. And then there's another type of a procedure called segmentectomy, where you remove a segment of the lung. So this is not quite a lobectomy, not quite a wedge resection, but in between. So you remove a larger portion of the lobe that contains the tumor. So these are three different types of surgical approaches. There are different types, but I just mentioned the three common types of lung cancer surgery. Radiation therapy now is an alternative. It's a type of a treatment that uses high-powered energy beams, such as X-rays, to kill cancer cells. And this would be an alternative option for patients who still have early-stage disease, but are not good candidates for surgery because of multiple other medical issues, pre-existing lung disease, so a compromised lung function, pre-existing cardiac disease, where it would be very high risk to undergo removal of a portion of lung. So in this situation, an alternative would be radiation therapy, a much more safer approach, yet a very effective approach in killing the cancer cells locally. Now, where else can radiation be utilized? Well, in patients with advanced cancer, radiation is a therapeutic strategy to alleviate symptoms. So, for example, if there's a very painful lesion in the bone because of cancer spread to the bone, radiation is a very effective way to help with the pain or the symptoms. Or if there's a very large tumor that's compressing the airways and there's difficulty breathing, radiation sometimes can be utilized in conjunction with other therapies to try and shrink the tumor and open up the airways and allow for better breathing. And this is called palliative radiation. It's different from what's called definitive radiation, where you use that as an alternative for surgery in early stage disease. Radiation also is the primary modality to treat cancer that has spread to the brain, because a lot of the treatments that are given for advanced disease will not penetrate the brain. The brain is a separate compartment. It's protected from the rest of the body. There is literally a barrier called the blood-brain barrier. So in order to treat cancer that has spread to the brain, radiation is the most effective modality. How does radiation inert its effects? Well, radiation is given through an external source, and it damages the DNA, as you can see here. Eventually, with DNA damage, the cancer cells are unable to replicate, and then they die off. The most common approach to treat via radiation is through an external source. So this is a machine, for example, it's called a linear accelerator. This machine will direct radiation beams from the outside to an area where the tumor is, and with the goal of killing that tumor cells. So patients usually will be laying in a flat position, usually in a fixed position, and radiation beams kind of circulate or rotate to exactly where the tumor is located. And this involves a very comprehensive treatment plan that includes a radiation oncologist who serves as the primary person who is in charge of the treatment plan. It involves multiple other specialists, such as physicists, dosimetrists, to figure out a very complicated radiation plan that will allow to treat effectively and safely to minimize the risk of side effects. This is a typical radiation treatment schedule. So oftentimes radiation treatments are administered on a daily basis, Monday to Friday. And as you can see here, daily treatments, Monday, Tuesday, Wednesday, Thursday, Friday. And the typical duration for radiation treatments for lung cancer is about 30 to 35 treatments, so approximately 6 to 7 weeks. Systemic therapy. So systemic therapy is actually where I specialize in as a medical oncologist. And this type of treatment utilizes drugs or medicines to treat cancer, either through the IV or through oral pills. These drugs then circulate throughout the body and kill cancer that's anywhere. So not just directed towards the lung, but if the cancer has spread to any part of the body, the only effective way to address that cancer is through systemic therapy. All the other types of treatments I talked about, surgery or radiation, are what's referred to as local therapies. They only treat the specific area where the radiation is addressing. So if you get radiation to the lung, that's the only area that will be affected. It will not affect any other part of the body where the cancer has spread to. So that's why the most effective way to address advanced cancer is with systemic therapy. There are different types of systemic therapies, which include chemotherapy, immunotherapy, or targeted therapy. So these are the three generalized categories of systemic therapy that are utilized in lung cancer. So we'll talk about chemotherapy first. Chemotherapy, kind of loosely used as a term to describe any type of medicines or drugs that are used to kill cancer cells. But for the purpose of my lecture, when I say chemotherapy, I'm referring to traditional cytotoxic chemotherapy. This is a type of cancer treatment that utilizes specialized chemicals to kill fast-growing cells. So usually given through the IV, as you can see in this picture, goes into the body and kills rapidly dividing cells, and almost is not able to discriminate between normal cells or cancer cells. But of course, cancer cells replicate at a much higher rate than normal cells. So yes, there's much more damage being done to the cancer cells. But there are also normal cells that divide fast. They have a fast cycle. And so part of the side effects of chemotherapy is because the chemotherapy affects normal cells. Works in many ways, directly damaging the DNA of the cell, altering the structure or the function of the cell that renders it incapable of dividing or replicating. And that's how the cells eventually die off and they're unable to continue to grow. Typically administered through an IV route. So examples of chemotherapy that is used commonly in lung cancer is cisplatin or carboplatin. So platinum-based drugs can be used by itself or in combination with other types of systemic therapies. So there are various ways to use or incorporate chemotherapy into the treatment plan. Not everybody needs chemotherapy, but a good proportion of patients will require chemotherapy at some point during the lung cancer treatment paradigm. Immunotherapy is a different type of treatment. I don't want to say it's novel because it's been around for at least a few years, but relatively new in the grand scheme of cancer therapeutics. Immunotherapy is an interesting approach because it utilizes the body's own immune system, and it enhances the body's own immune system and stimulates the immune system to be able to recognize and attack the cancer cell. So think of the immune system as a surveillance for the body. It is able, the immune cells are circulating throughout the body and is able to recognize anything that's considered foreign. So for example, viruses. The immune system is able to recognize the virus as a foreign agent or a foreign cell and is able to clear it on its own. Of course, cancer cells are far more clever than viruses. And so cancer cells have devised mechanisms to hide from the immune system, and they do so very effectively, which is why cancers continue to grow despite having a robust immune system. Immunotherapy harnesses the immune cells or the immune system's capability and machinery to be able to augment the immune system's ability to fight cancer cells by really amplifying the immune system. A group of drugs referred to as immune checkpoint inhibitors is a type of immunotherapy very commonly used for lung cancer. It works by blocking immune checkpoints, hence the term checkpoint inhibitor. These checkpoints are considered the brakes of the immune system. These brakes are part of our own body's inherent machinery, which serves an evolutionary purpose, because if there are no brakes on the immune system would be in constant activity, and that would cause inherent damage to the body. The immune system is too active and it starts to attack your own body. So there are naturally brakes in place to regulate the activity of the immune system. And these are called immune checkpoints. When there's cancer, of course, cancer will exploit these immune checkpoints and hide from the immune system. So what these immune checkpoint inhibitors do is essentially block these checkpoints, allowing the immune cells to recognize the cancer and exact its influences on the cancer. This is a type of a checkpoint called the PD-1 or PD-L1 pathway. As you can see here, when cancer cells are recognized by the immune system, the T cell is a part of the immune system, which is considered the killer cell. So it's the cell that is able to recognize, attack, and kill foreign cells. However, when there are these checkpoints at play, it blocks the T cells from inserting its effects on the cancer cells. So as you can see here, the PD-1, PD-L1 interface, there's a blockage in that communication. Essentially, what immunotherapy does is allow that T cell to inert its effects by blocking that pathway. So when drugs such as PD-1 or PD-L1 inhibitors are given to a patient, they really enable the immune system to not only recognize, but even to eliminate the cancer cells. Examples of immune checkpoint inhibitors for lung cancer include a drug called pembrolizumab, another name for that is Keytruda, durvalumab, another name for that is Imfinzi, or atezolizumab, another name for that is Tecentriq. And these are very commonly utilized immune checkpoint inhibitors that are very effective for the treatment of lung cancer. The third category of drugs is referred to as targeted therapy. Targeted therapy is a type of cancer therapy that targets certain proteins that are expressed on the cancer cells that allow it to grow uncontrollably. So there are certain cancer cells that have an overexpression or an increased activity of a certain type of a protein that sits on the surface of the cells. What targeted therapy does is attack those specific proteins, prevent those proteins from signaling downstream and communicating with the cell's DNA to continue to grow and proliferate. A group of proteins is referred to as tyrosine kinases, or TKs. These proteins play a very critical role in signaling cell growth. And when there are mutations in these tyrosine kinases, cancer cells will start to grow and develop and spread. Hence, tyrosine kinase inhibitors, or TKIs, are a group of targeted therapies that block these signals and eventually kill some of these cells and prevent some others from growing. So targeted therapies are specifically designed for a specific type of a mutation. And this is an image of the mutational landscape of adenocarcinoma. Not everybody with lung cancer has specific mutations, right? These tyrosine kinase inhibitors are designed to specifically target some mutations, and they only work, or they work best in patients with specific mutations referred to as driver mutations. Driver mutations means these are the mutations that drive the growth of the cancer. And there are at least 7 or 8 recognized mutations for lung adenocarcinoma, where it's most commonly seen, for which there is an FDA-approved oral targeted therapy. Of course, there are mutations outside of these 7 mutations, but there are not yet currently available drugs that can attack or address the mutations. So currently there are about 7 drugs that we utilize if there are any of these mutations. So targeted therapy is a much more precise mechanism of killing cancer than the other treatments that I mentioned earlier. So how do we incorporate these systemic therapies into the treatment plan for lung cancer? Well, one way is called adjuvant therapy. Adjuvant therapy means systemic therapy administered after surgery. So after surgical resection in patients with stage 2 or stage 3 disease, which means disease that involves the lymph nodes or larger sized tumors, chemotherapy is given with the goal of increasing the chances of cure. Chemotherapy is given with the goal of killing off any microscopic cells that are not visible on a scan and preventing the chance of the cancer coming back. And this is usually with a 2-drug regimen given every 3 weeks for a total of 12 weeks. So that's a typical way to treat lung cancer after surgery with chemotherapy in the adjuvant setting. Now, sometimes chemotherapy might be given before surgery. If it's a large tumor, but otherwise, we want to try and optimize the surgery, chemotherapy is given to shrink the tumor to allow for an optimal surgical resection. So it can be utilized in both ways, but most commonly it's given after surgery, called adjuvant therapy. Well, where else can systemic therapy be given? Well, it can be given as part of combination therapy in combination with radiation. So in patients with stage 3 disease, where surgery would not be optimal, which is the vast majority of patients with stage 3 disease, it's not resectable. So in such a situation, the ideal treatment of choice is to combine chemotherapy with radiation. Oftentimes, chemotherapy in this situation is given once a week for the entire duration of radiation, which amounts to about 6 to 7 weeks. Following that, immunotherapy using a drug called durvalumab is given as a maintenance for up to a year. So this approach helps prevent the progression of cancer and further augments the treatment effects from the chemotherapy and the radiation up front. And this approach has really been a game changer in terms of improving the prognosis of patients with stage 3 disease. Historically, patients with stage 3 disease was treated with just chemotherapy and radiation, and that's it. With the recent development of the immunotherapy drugs, this has been incorporated into standard practice for about 3-4 years now. And that has really translated into an improvement in survival from about 2.5 years to in excess of about 4 years now for patients with stage 3 disease. So that's quite a substantial improvement. Systemic therapy is really the primary therapy for patients with advanced disease or stage 4 disease. The goal here in this situation is what's called palliative treatment. Because the cancer has spread beyond where it originated, cure is less likely. And so the goal is really to shrink the tumor, improve symptoms because of the disease, control the disease, keep it at bay, and prevent spread of the disease, all while preserving the quality of life. And this can be achieved with any type of systemic therapy, whether it's chemotherapy, immunotherapy, or targeted therapy. And ultimately, the type of therapy is individualized based on the type of lung cancer and based on the patient's molecular profile, based on the presence or absence of mutations. If patients have these driver mutations, as I referred to earlier, the preferred approach is targeted therapy using oral drugs. But these mutations are only seen in about 15 or 20% of patients with adenocarcinoma, which means the vast majority of patients with advanced cancer don't have these specific mutations for which there are FDA-approved drugs currently available. In those situations, the standard treatment will be a combination of chemotherapy and immunotherapy. And in some patients, they may derive such a good benefit from immunotherapy where there may not be a need for chemotherapy, at least up front. And so you can treat with immunotherapy by itself. So ultimately, the way we formulate a treatment plan for patients with advanced disease is individualized. In the past, it used to be a one-size-fits-all. Everybody gets chemotherapy. Well, now it's more so chemotherapy with immunotherapy in some folks, immunotherapy by itself in some folks, targeted therapy in some folks. So this this precise way of addressing treatment is called precision medicine, and that's really helped to treat patients, to avoid drugs that don't work, and to maximize outcomes from delivering drugs that work best for that particular patient. This is a typical type of a treatment schedule, in most patients who receive chemotherapy with immunotherapy. So there's an initial phase called induction or initial treatment, where patients will receive a combination of chemotherapy and immunotherapy for 4 cycles, which is about 3 months, 12 weeks, after which there's a scan to see if the cancer has regressed. And if that's the case, then most patients are eligible to be on what's called maintenance therapy. And this is oftentimes with just a single agent immunotherapy. And this will continue for as long as the cancer is responding, and for as long as the patient is tolerating without any significant side effects. So that's kind of a typical way of approaching stage 4 lung cancer in most patients. This is a neat table I want to bring to your attention that really highlights how the outcomes of patients with lung cancer, advanced lung cancer, has really changed over time with the advances in treatment and with the development of novel therapies. So if I bring your attention to the first column here, if there is no treatment, no chemotherapy, no treatment period, the median survival is about 6 to 7 months without any treatment at all. Now, of course, there are variations, depending on the burden of disease, where the cancer has spread, and so forth. The chances of being alive at 1 year is 10% or less. Historically, the treatment for advanced lung cancer in the past used to be just chemotherapy using a 2-drug-based regimen. And with a 2-drug chemotherapy regimen, the median survival is anywhere from 10 to 12 months. It's about 11 months roughly. Chances of being alive at 1 year about 40%. And a response rate of 30%, which means 30% of the people that receive this combination will have a response. The development of targeted therapies, and with the identification of these driver mutations, patients who have these mutations that are treated with targeted therapies, the median survival has been in excess of 30 months, closer to 40 months. So that's a substantial difference compared to 11 months, as you can see. Triple the survival. And the chances of being alive at 1 year is in excess of 80%, 85%, almost 90%. And then with the use of immunotherapy, the chances of being alive more than 70, 80% at 1 year. And the median survival is in excess of 24 months, 30 months in some folks. Now, of course, these are numbers kind of based on studies. There are individual variations. And so the survival in advanced lung cancer depends on many factors. It depends on how much disease there is, how much of a burden the disease is placing on the body, how fit an individual is, how many other medical issues a patient has, and how able is the patient to be able to receive these treatments without taking a major beating. Is there cancer spread to the brain? So these are all variables that needs to be taken into account when we look at prognosis and survival. Are there mutations for which targeted therapy can be used? If so, the prognosis is far better than if there are no mutations. Right? These are some, in conclusion, these are some resources that are very useful to get, some valuable ideas on lung cancer treatment, lung cancer diagnosis, statistics. The National Cancer Institute, particularly www.cancer.gov, is what I usually encourage patients to look up. American Cancer Society, very reliable resources to be able to get information on lung cancer treatments, lung cancer diagnosis, risk factors, screening, and so forth.